Welcome to the first virtual speaker series for Mom. Our first guest is Dr. Mylea Charvat of Savonics Inc. She's a champion for Alzheimer's after her grandmother was diagnosed, and she's seen firsthand how cognitive diseases affect families and patients.
Well, this is a really common question. I think it causes a lot of confusion. Dementia is sort of like an umbrella term, the way that cancer is an umbrella term. But just like there are many types of cancer, there are different types of dementias. Alzheimer's is the most common type of dementia. There are others, like Lewy body dementia and temporal frontal lobe dementia. We're talking about Alzheimer's today, of course, and Alzheimer's is typically considered the most common type of dementia, compromising about 60 to 80% of cases of dementia globally. Unlike dementia, Alzheimer's is actually a specific neurodegenerative disease that is typified by things like plaques and tangles in the brain that cause specific kinds of symptoms, like impairment in language and memory skills. There are many stages of Alzheimer's disease, and actually dementia more broadly. There are typically considered to be 7 stages, from early stage to late stage, and they're typified by different severity of symptoms. So for instance, in the early stages, maybe stages 1 to 3, the only people who might really notice that something is wrong are close family members who start to notice subtle changes in behavior and memory and ability. But as the disease progresses, the deficits and symptoms become obvious even to people that don't know the person. The most prevalent risk factor for developing Alzheimer's is the presence of the ApoE4 gene. And this is something that can be tested for. I think one of the common misconceptions is that Alzheimer's disease is predominantly or primarily a genetic disease. And while genes are a major risk factor for developing the disease, there are also a myriad of lifestyle factors that influence how those genes get activated. We say that genetics loads the gun and environment pulls the trigger in medicine. What we're saying is that while genes provide a certain level of risk, that certain behaviors that you might engage in throughout your life are going to either increase the likelihood that that gene is activated or decrease the risk. So for example, lifestyle risk factors for Alzheimer's disease include things like a poor diet, poor sleep, smoking, and a sedentary lifestyle. And these are things that we can control. So just like when we think about heart disease, we can start thinking about risk factors early and in midlife to reduce our risk of getting Alzheimer's, even if we have elevated genetic risk. And one of the things that's really important is to monitor for early symptoms. And this is why early and frequent cognitive testing is critically important. Just like we check blood pressure starting when we're younger, even in our 20s, we should be looking at cognition early and in midlife to determine what we're looking at in terms of early symptoms and early risk for the disease. The way that Alzheimer's is diagnosed today is as what we would call a rule-out diagnosis. So there's going to be a set of symptoms, say memory impairment, and we're going to look for other causes of that memory impairment, such as a thyroid condition or a vitamin deficiency, before we're going to say that it might be Alzheimer's disease. And this is because we really don't have a single test to determine if Alzheimer's is present. And part of that is that classically we've thought of this as one disease. But as we learn more about the disease, we learn that it may actually be many different types of diseases with common underlying symptoms. So for example, for a long time, it was thought that the presence of beta amyloid plaque in the brain was a positive biomarker and is a good test for Alzheimer's. But the fact is that many people that develop Alzheimer's symptoms have no plaque, and many people with abundant plaque in their brain never develop symptoms. So it's not a yes-no indicator for the presence of the disease. The way that we do it right now is by using neuropsychological testing to look at cognitive impairment, and then to look at the domains that are impaired. So are the domains that are impaired in the areas that we understand are implicated in Alzheimer's, like language and memory, especially episodic memory? Or are they in other types of cognition, like maybe attention or visual spatial skills, which might indicate another type of neurodegenerative disease, such as a different type of dementia, like Lewy body dementia? So as you can see from my answer, it's a very complex process where a lot of data is taken in to make a consideration, and then a diagnosis is typically estimated or rendered by the clinician. Right now, the only absolute way to confirm Alzheimer's is by autopsy after the person has died from the disease. There are advances in neuroimaging, but again, these are late stage diagnostic markers because the changes associated with Alzheimer's in the brain don't really show up in brain scans until much later in the disease. So it's not considered a good method for early detection. Right now, there's no actual cure for Alzheimer's disease, but there are many things that we can do to slow the progression of the disease. In the realm of pharmacotherapy, or medications that can be taken, there are cholinesterase inhibitors, memantine, and antipsychotics and antidepressants, which can often be prescribed to lessen certain symptoms of the disease or slow the progression of the disease. There are also other therapies that are available, like cognitive therapies, and even certain cognitive activities to boost neuroconnectivity in the brain. The reality is that the most powerful thing that one can do to slow the progression of the disease is to look at the lifestyle risk factors and to modify behavior. A really good example is that a study out of Exeter University in people with genetic risk for Alzheimer's and with early stages of the disease showed that a simple exercise program was able to slow and even in some cases reverse early stages of Alzheimer's in people with that genetic risk. So if I were to say, what is the one thing that you can do to slow the progression of the disease, it would actually be to become physically active. Physical exercise actually causes neurogenesis, or new brain cells, to grow in the brain, which is one of the most powerful things we can do to slow the progression of a disease that is killing or degenerating those cells in the brain. Alzheimer's is a very complicated disease. That's almost like asking, why don't we have a cure for all cancers yet? Because we're talking not about one disease, right? But about a complex set of symptoms that probably comprise many diseases. One of the biggest things is that there's a lack of awareness from people affected. There's a lack of early detection to refer people to clinical trials. There's a lot of stigma around the disease. And again, we are dealing with different, what we call underlying pathologies or causes of the disease. I talked about plaque a little earlier, that's one. But if I enroll someone without plaque in a drug trial that's targeting plaque, I'm not going to see improvement in that patient because I'm not targeting the right thing for that patient in the trial. It's very complex to enroll people in the correct studies for this disease, given the different pathologies or ways that the disease can develop. So it's a really complicated question. The other thing that is really problematic is that we really don't have good animal models for Alzheimer's. We can do things, for instance, in epilepsy to induce a seizure in a mouse and then think about how to address that with a drug. We can't really induce Alzheimer's in animals, and so it's very difficult to build the animal models to underlie drug both efficacy and safety before moving into human trials. Then when we get into human trials, the major source of referrals for clinical trials are actually doctors who see patients in their office and then refer that person to a trial that might be appropriate for them. Our lack of early detection in the clinical care system is hurting us. A recent estimate that I heard from an Alzheimer's researcher is that 48% of clinical trials in Alzheimer's fail because they never get fully enrolled. So we don't even know if that particular drug could have been our breakthrough because we never get to complete the study. And the reason for that is that we're not identifying people early enough in the disease to qualify to even be in the studies. So we have large hurdles to overcome. One of the biggest things that I'm focused on is actually the early detection piece, because I believe if we can detect symptoms earlier, we can take a vicious cycle right now of degenerative disease and lack of available treatment options and lack of completion of clinical trials and turn that into a virtuous cycle by finding people earlier, giving them the hope and the opportunity of a clinical trial, thereby enrolling that clinical trial, completing it faster, and hopefully, yes, getting to an answer or at least some options for cures during our lifetime.